So welcome everybody. Thank you guys for coming. Today we have Dr. Kosar talking to us about the thoracic spine and the link between the neck, shoulder, the lumbar, and the visceral pain patterns. He graduated from University of Pittsburgh with a bachelor's degree in rehabilitation science and earned a master's degree from the University of Delaware in anatomy and clinical health prior to receiving his DPT from the University of Delaware. He graduated from St. Luke's University Health Network Orthopedic Residency as co-chief resident in 2019, and is currently the facility director at physical therapy at St. Luke's at Fogelsville. He's worked extensively with patients with spine pain and has been a mentor to his colleagues on disorders of thoracic spine. So without further ado, I will turn it over to thoracic. Actually, one further ado. Make sure you do sign in, and if you're New Jersey, make sure you also sign out. And if you didn't get scanned by me, come to me later. Everything's going to be sent to you on my e-learning, so make sure you look for that. And if you have questions about how to get your certificate, it's also on my e-learning, so just do that. And then people online, the link will come out as soon as the my e-learning people are able to process it, so about 1 day to 1 week is what I'm given for a timeline. So you'll get an email from me, just click on the link. So I'll turn it over, Dr. Kosar.
All right, thanks, Steve. Co-chief president, there was only two of us, so I guess we were both co-chiefs. But so, like I said, I'm talking about the thoracic spine. I'm going to talk about how it's a link between upper quarter pain patterns, lower quarter pain patterns, and what to be aware of for visceral pain in that area. I have no financial relationships to disclose. These are the objectives. I'm not really going to read them out, but they're there for your reading leisure, if you do so, please. So the reason why I was interested in this topic was back in the residency, I had some shoulder patients. They had shoulder pain, did a classic shoulder eval, decreased strength, decreased motion, hypermobility, all that stuff. But they weren't getting as better as fast as I thought they would. They still had some pain towards their end range shoulder motion, and they weren't able to go up quite as high. So then one of my mentors was like, why don't you check out the first rib mobility and thoracic mobility? So I was like, okay, let's see how this goes. So I did some first rib mobs. Then I did a test retest, so I had them lift their arm up again, and their arm went right up to full range of motion, and they had decreased pain. So my mind was blown at that point, because in PT school you learn about the thoracic spine and how it affects the thoracic spine. Not really much about anything else. You also learn about neck pain with the thoracic spine, but anyway, so that was basically the jump point as why I was interested in this topic. So before we really get into the thick of it, I'm just going to briefly review some anatomical things. So there are 12 thoracic vertebrae. They vary by the region in the thoracic region. So the superior segments share commonalities with the cervical spine, and the inferior segments become more like the lumbar spine. So the vertebral bodies become more larger and more dense from superior to inferior to support the increasing loads. The height of the vertebral bodies in the thoracic region is more posterior, which attributes to the kyphosis. And the thoracic facet joints are synovial in nature and in structure, and they are primarily oriented in the frontal plane, with the inferior articulations matching the superior articulations, and they face anteriorly, inferiorly, and a little medially. And this is why the thoracic region is mainly known for rotation, because of how the facets are aligned as opposed to flexion extension like the lumbar spine. Just for palpation purposes, the rule of threes, I like to call it. So if you're palpating the spinous processes of T1 through T3, you're going to be palpating anatomically at the same corresponding level of the transverse process in that vertebral body. So if you're palpating T2 spinous process, you're going to be on the same level as T2 anatomically. If you're palpating T4 through T6, you're going to be spinous process, you're going to be palpating 1/2 vertebral level below that. So if you're palpating T5 spinous process, you're actually going to be anatomically between T5 and T6. And then if you palpate T7 through T9, you're 1 full vertebral level below. So if you're palpating T8 spinous process, you're actually going to be at the level of T9 anatomically. And then T10 through T12 level out, and when you palpate those spinous processes, they will be at the same corresponding level as the transverse process and vertebral body. I'm getting a little bit about the ribs. There's 12 of them. There's a couple ways of describing them, so you can go describe them as true ribs and false ribs. The ribs 1 through 7 are the true ribs, and they are the true ribs because they directly attach to the sternum. And then there's the false ribs, or ribs 8 through 12, and they don't directly attach to the sternum, as they distally attach to the costochondral cartilage of the superior rib, or as ribs 11 through 12, they're floating ribs. You can also describe them as typical and atypical. Typical ribs are ribs 3 through 9, and they are typical because they have 2 facets for the attachments to the corresponding facet on the vertebral bodies, with the inferior facet attaching to a numerically corresponding vertebral body. So for let's see, for rib 3, it's a typical rib because it has 2 facets, one on rib thoracic vertebrae 2 and one on thoracic vertebrae 3. And it's called rib 3, that was weird, because inferior articulation is on rib 3. And then the atypical ribs are ribs 1, 2, 10, 11, and 12, and they only attach to 1 facet on the corresponding vertebral body, while the second rib actually does have 2 facets, but it's atypical just because of how it attaches to the junction of the manubrium and the sternum. So getting into more of the spinal cord in the thoracic region, so you have the critical zone, which is between T4 through T9, and it's called the critical zone because the spinal cord in that area has a smaller diameter in the vertebral canal compared to other regions. And in that region, you also have something called a tension point, which is T6. And then this is an area where the motion of the spinal cord relative to the spinal canal converges in different directions. So one of the articles I read postulates that during flexion of the cervical and thoracic spine, similar to the slump position, the cord in relation to the spinal canal moves cranially toward the cervical spine and caudally toward the lumbar spine. So mobility impairments in this middle thoracic region can contribute to signs and symptoms associated with adverse neural tissue dynamics. And the reason why I have the tension point and sympathetic chain highlighted is because those will play into part later on in the presentation when I get into more of the treatment and things like that. These are just pictures depicting what I just really talked about. As you can see, the one on your left shows a nice picture of the critical zone in the thoracic region, how it gets smaller in diameter there. And the one on the right shows the sympathetic chain and how close it is in proximity to the thoracic region and the costovertebral joints. And just a couple things about the sympathetic innervation. So levels T1 through T2 are innervate the head region. Levels T3 through T7 innervate the upper extremities. Levels T7 through T12 innervate the lower extremities. And levels T1 through T12 innervate the whole trunk. All right, getting into the organs in the region. The reason why I chose these specifically is because these also have referral pain patterns into the thoracic region. So you have the lungs, the heart, the liver, the gallbladder, the stomach, and the pancreas. Before we really get into those referral pain patterns, though, I want to review visceral pain because it is important to really keep these in mind, as especially nowadays with direct access that we have, patients might come in and our objective evaluation might not really add up to what's going on. So we really got to keep in the back of our mind, hey, something else could be going on here, we need to refer out. So visceral pain can be described as dull, poorly localized. It may be associated with autonomic symptoms such as pale skin, profuse sweating, nausea, GI disturbances, and changes in body temperature, blood pressure, and heart rate. And like I said, if something's iffy during your objective evaluation, such as nothing's really changing during your mechanical assessment, to start to creep up in your mind about something else is going on. So this is a nice picture depicting some of the thoracic referral patterns from the organs I listed prior. So you have the lungs and diaphragm in the upper left. And that's not really the thoracic region, but still basically there. You have the liver and gallbladder upper right, as well as the infrascapular region on the right. You have the heart in the upper thoracic region, the stomach in the middle thoracic region, and then you have the pancreas in the thoracolumbar junction on the left. Some of these referral pain patterns can actually be explained by the levels that the organs are innervated by. So for instance, the stomach is innervated by some of the levels of the thoracic spine in the middle thoracic region, which is why sometimes that referral pain can refer to that mid-thoracic region. Just some things to really take note of per each organ separately, just during the subjective evaluation. If things aren't adding up, I know we always talked about the heart, we know about heart attacks, but we just want to review them. So things to look for are chest discomfort, nausea, lightheadedness, and vomiting, left upper extremity pain, the upper thoracic pain, which is what ties into this lecture, jaw or neck pain, which people sometimes forget about, and shortness of breath. And some of the causes that people have found, or articles have found, that really can refer to that upper thoracic area are myocardial ischemia, myocardial infarction, the big one, and then a dissecting thoracic aortic aneurysm. Liver and gallbladder, I kind of combine these together just because they have the similar referral patterns, but not necessarily similar signs and symptoms. So for pain after eating, especially more fatty foods, that's more of a gallbladder issue, but also jaundice is a big liver issue, dark colored urine, nausea, vomiting, right shoulder or infrascapular pain, again tying into the thoracic region. And you also want to, if something is in the back of your mind, something else is going on, you do start want to feel the abdomen area for, it's tenderness in the right upper quadrant, pain and tenderness. Usually in the clinic, we'll probably more see with direct access. If it is a visceral issue between these two, you'll probably more see gallbladder issues because livers tend to be more of a blunt trauma unless it's cirrhosis or cancer. For stomach and pancreas, you want to look for the stomach specifically, poor appetite, unexplained weight loss, abdominal pain, mid-thoracic pain, heartburn and indigestion, nausea, vomiting, blood and stool, and also something kind of interesting is it can be triggered orally by eating. Most commonly, something in the stomach that can refer to that mid-thoracic region is a peptic ulcer affecting the posterior wall of the stomach or duodenum. And then for pancreas, you want to look for pain in the upper left abdomen, pain that worsens after eating or drinking, again with fatty, high fat content. But again, that's the thing for a gallbladder, so you also want to take into account where the pain is in themselves and if it's in that infrascapular region, which is the gallbladder issue, or the thoracic lumbar region on the left, which is the pancreas issue.
I figured you would be for half an hour.
And then we can hear somebody, so we're going to mute you. I apologize.
Because I still have somebody at 10, so I couldn't.
So,
sorry about that. All right, and we're back. All right, I didn't really include the kidneys in this, even though they do refer to the costovertebral angle or the flank area, but those are usually talked about in lumbar lectures, and that's the reason why I didn't really include them in this lecture. Other red flags to note: cancer. Obviously, a history of cancer is a big one. So if a patient has a history of cancer and things aren't adding up in your evaluation, automatically start to think about that. Night pain or pain at rest, unexplained weight loss, age less than 17 or greater than 50, and failure to improve after 1 month of conservative treatment. Now, the thoracic region doesn't really have primary tumors in it. Those are more less common, but the cancers that are common that metastasize there are primary breast, lung, and colon cancers. You also want to be aware of vertebral fractures, both traumatic or osteoporotic. Things in the subjective, you want to take note if their patient was on prolonged use of corticosteroids, age greater than 70, mild trauma, age greater than 50, and by mild trauma, that can be anything such as a near fall, which means the patient's about to fall, but they catch themselves before they actually fall. That little bit of a trauma, especially for people who are older or osteoporotic, can actually cause a vertebral fracture. Again, no history of osteoporosis and the major trauma at any age. There's actually a CPR for vertebral fractures. It's age greater than 70, female gender, significant trauma, and prolonged corticosteroid use. And the presence of 3 or more of these increases the probability greatly that someone will have a vertebral fracture, or someone has a vertebral fracture. And vertebral fractures are more common in the lower thoracic area, as opposed to the upper. Ankylosing spondylitis. This is a chronic rheumatoid disorder. This usually originates in the sacroiliac region, but again, because of the direct access that we have, it can progress to the superior portions of the spine, such as the thoracic region, and affect both the thoracic spine and costovertebral joints. So things to take note for this are marked morning stiffness lasting greater than 30 minutes, alternating buttock pain, night pain during the second half of the night, and symptoms improve with exercise. So that's actually its own CPR in itself, and 3 out of the 4 of those, getting into stats now, but it's specificity of 97% with a positive likelihood ratio of 12.4. Basically, all that means is if you have 3 out of 4 of those, there's a higher likelihood of the patient actually having ankylosing spondylitis. People are more likelihood of getting it if they have a hereditary factor, which shows that there's a genetic component, and there's a higher incidence in males. Not that this is really a red flag, but I didn't really know where else to include it in the presentation, but thoracic discogenic pain, which is no longer an uncommon cause of thoracic pain, is, and the most common symptom of it is disc herniations, is in the anterior chest. So if patients have anterior chest pain, and again, you're pushing on it and nothing's really working, or you can't really figure anything out, start to look into the posterior region in the thoracic area, because it could be a disc herniation. All right, getting more now into the biomechanics. Start off with just the thoracic region in general. So for flexion, the superior segments go superiorly and anteriorly. Extension's a complete opposite, glide inferiorly and posteriorly. Side bending, you have kind of an opposite thing. You have the ipsilateral side going inferiorly and posteriorly, and the opposite side going opposite of that. And then rotation, you have the superior segments going inferiorly and posteriorly as well. So same thing as side bending, kind of like that with my hands. And then, so I want to briefly mention coupling, because I know some people are big into that, especially about the cervical and lumbar region. In the upper thoracic, coupling occurs to the same side, at least that's what I found most often in research articles. So if you side bend to the right, the thoracic vertebrae will rotate to the right as well. And in the mid and lower thoracic, coupling can go either way, with research showing more common that the lower thoracic spine follows the lumbar spine coupling, which is actually opposite of the upper thoracic. So side bend to the right, this lumbar spine actually rotates to the left. Again, that's also up in the air, but that's most commonly what the research just shows. These are just pictures depicting what I just talked about. You have the flexion, extension, side bending, and then rotation. Getting more into the ribs. So the ribs kind of follow what the thoracic spine does, but for flexion, the ribs go anteriorly and glide superiorly. Extension is opposite. They glide inferiorly and rotate posteriorly. Side bending, they approximate ipsilaterally and separate contralaterally, which makes sense, while they glide inferiorly and then on the ipsilateral side and superiorly on the contralateral side. And then for rotation, the ribs posteriorly rotate and inferiorly glide ipsilaterally and anteriorly rotate and superiorly glide contralaterally. So again, kind of like the same thing as the thoracic region. So if you're kind of like that motion right there. So now I just want to briefly talk about regional interdependence. That's what this whole talk is mainly about. But now I'll be talking about more how the thoracic region moves with other parts of the body. So this quote I liked. It's the concept that seemingly unrelated impairments in a remote anatomical region may contribute to or be associated with the patient's primary complaint. So again, this is important for us, as in patients might come in with ankle pain or some other pain that, even though the pain's down there, doesn't necessarily mean that's what the issue is. There could be something proximal, could be causing irritation down at the ankle, and if we don't fix that initial reason, that you're never going to fix the actual problem. And this is just a nice picture by Leah. So for the thoracic biomechanics during shoulder motion, for bilateral upper extremity elevation, the thoracic region extends. And then for unilateral upper extremity elevation, the thoracic region rotates and side bends ipsilaterally. So going back to the biomechanics, for the extension and ipsilateral rotation and side bending, everything's going to basically posteriorly rotate and inferiorly glide. Posteriorly glide and inferiorly rotate, or vice versa. Anyway, it's going to kind of go like this or like that, which is something to take note as to why some of our manual techniques we choose work. And then also this is a big reason why, when the classic example, when you tell people to stand with poor posture and have them raise their arms up, they can't really go that high. But then when you have them sit up nice and straight, their arms go up way higher, except I'm wearing a suit, so my arms don't go high anyway. And this article I found I actually kind of liked. It's more about how the thoracic region influences cervical movement as opposed to how the biomechanics of it. So this graph shows general percentages of the cervical region, upper thoracic region, and lower thoracic region during cervical flexion, extension, rotation, and side bending. And as you can see, the upper thoracic region has about a quarter of the influence on the cervical flexion extension and not as much during rotation and the side bending. And this graph kind of puts that spatially, as well as includes the range of motions that are typical for normal range of motion. As you can see, again, it just depicts how dominant, obviously, cervical movement is during cervical motions. But you can see for the flexion extension how the upper thoracic, which is the big, thick dotted line, has more of a contribution as opposed to the others. And this is why there's a lot of research out there about why addressing the thoracic region can affect cervical pain. All right, so what does the research say about how addressing the thoracic spine impairments affecting neck pain, shoulder pain, etc.? I'm going to talk about mechanical neck pain first, since that's the most common reason why usually people like to do thoracic manipulations or mobilizations. So this was this is actually a fairly newer article, but it's a randomized controlled trial, and the purpose was to investigate short-term effects of the thoracic spine thrust manipulations combined with cervical spine non-thrust mobilizations and an HEP consisting of active range of motion exercises versus only cervical spine non-thrust mobilizations alone in patients with mechanical neck pain. So there's 64 patients divided up into two groups. Patients only had two sessions, and the outcome measures were collected at baseline and that 1 week follow-up. The experimental group had significantly greater improvements on both the numerical pain rating scale, the NPRS, and the neck disability index, the NDI, at the 1 week follow-up. Also, 31 out of the 33, which is 94% of the experimental group, which is the group that included the thoracic manual techniques, compared to only 11 out of 31, which is only 35% of the control group, indicated a global rating of change of +4 at the 1 week follow-up, and the number needed to treat to get these good results is only 2, which is really good. Some limitations to this study was it was only 1 week follow-up, so not very long term. There was only one physical therapist that did this, and there was no analysis of the placebo effect. Another randomized control trial I found, the purpose was to compare the effectiveness between non-thrust and thrust manipulations to the thoracic region for patients who had mechanical neck pain. 103 patients were included in this study, and this study actually found that there was equivalent outcomes between non-thrust and thrust thoracic manipulations for the NDI, the NPRS. This even looked at deep cervical flexion endurance, number of visits, and duration of care. So again, a lot of studies found that manipulations were better. This one actually found they were about the same, but there's also limitations to each, so just keep that in mind. And a lot of older studies either not really talking about, especially involving Cleveland, did show benefits of the thoracic manipulation over everything. And actually a systematic review in 2019 showed that thoracic spine manual techniques has been shown to be more beneficial than thoracic mobilizations, cervical mobilizations, and standard of care in the short term, but no better than cervical manipulations or placebo thoracic spine manipulations to improve pain and disability. Again, this kind of just contradicts what I just said about thrust and non-thrust being equivalent. This systematic review says thrusts are more better than the non-thrusts, but not as good or just equivalent to as cervical manipulations. However, not many people like to do cervical manips and are way more comfortable doing thoracic manipulations. Limitation of this systematic review was there was not a lot of high-quality studies in it, and it had a lot of heterogeneity. So overall, there's a lot of short-term benefits found for the thoracic spine manipulations, mobilizations, but not many long-term studies. And no study that I found really looked at giving HEPs that supplemented the thoracic manual techniques. They gave active range of motion exercises to keep the motion, but none of them really gave techniques such as like supine thoracic extension over a bolster or over a chair, things like that, to actually supplement what we're working on in the clinic other than just active range of motion. Getting into cervical radiculopathy, randomized control trial. The purpose was to compare thoracic spine thrust manipulations versus sham manipulations. Outcomes were measured at immediately afterwards, 48 hours after, 72 hours after the manipulation. The outcomes they looked at were the NPRS, the NDI, cervical range of motion, and deep neck flexor endurance. So one session of the thoracic manipulation resulted in improvements in pain, disability, cervical range of motion, and deep neck flexor endurance in patients with cervical radiculopathy. Patients treated with the manipulation were more likely to report at least moderate change in their neck and upper extremity symptoms up to 48 to 72 hours following treatment. And up to that 48 to 72 hours following treatment, a greater proportion of the participants in the manipulation group reported improvement, which they depicted as a global rating of change of +4. They depicted that in neck and upper extremity symptoms, centralization of symptoms, and beliefs about receiving active manipulation, compared to the sham manipulation group. Thoracic outlet syndrome. I'm not really going to go into the anatomy of this, but we're just going to briefly mention 3 areas that are common for where nerves are susceptible to increased loads, and those are the costoclavicular space, interscalene triangle, and the retropectoral space. So I really want to focus on the costoclavicular space because that is mainly a region where we can address not just with postural, but also with mobilizations to the first rib. And it was found that restoring mobility to the first rib can increase the costoclavicular space and reduce the imposed load on the neurovascular structures in the thoracic outlet. And also in general, for any thoracic outlet syndrome, usually it's a postural issue. And usually when we think of posture, it's always the kyphotic posture, forward head. So anything involving opening up that chest, which involves thoracic region, can also help with that. Briefly, we want to talk about T4 syndrome. I know it's kind of an enigma, but symptoms arise from T3 to T7. You have glove-like numbness and paresthesias in the hands and forearm, and those are more typically nocturnally and early morning. And they also can have possible headaches, neck pain, and feeling of tightness in the upper thoracic spine. And some typically, like the upper quarter screen reveals no deficits. So there was 2 cases on this. Again, not a lot of high-quality research. Same thing with the thoracic outlet. There wasn't many high-quality research for that either. But so 2 cases on this. Similar, the patients presented with symptoms similar to T4 syndrome, and the physical therapist treated what they deemed dysfunctional thoracic segments with joint mobilizations, manipulations. They also targeted stretching and strengthening exercises to that region. And doing that, they actually found good results. The patients got better, had no symptoms, and that's really all they focused on. All right, so now transitioning to the shoulder. So treatment of the thoracic spine may restore, there's research out there is basically anywhere from 5 to 15 degrees of thoracic extension needed for full shoulder elevation. So treatment of the thoracic spine can restore that. It can improve recruitment of muscles in the shoulder girdle, and it has a neurophysiological effect on pain and dysfunction. So a study of 139 laundry workers actually demonstrated that hypomobility of the cervico-thoracic junction could increase the probability of developing shoulder and neck pain in the following 12 months by threefold. In addition, pain and dysfunction of the second rib and cervicothoracic junction were identified in 40% of 101 individuals with nonspecific shoulder pain, which is basically just their broad term of saying patients who have shoulder pain, which was not present in age-matched asymptomatic individuals. So the first study I found was a systematic review. And the purpose was to investigate the effect of thoracic manual therapy with or without supplementary exercises. This is the first review for the author, to the author's knowledge, that focused on the thoracic manual techniques with or without supplementary exercises and excluded or controlled for what they deemed as shoulder girdle manual techniques in order to establish whether or not actually the thoracic manual technique was accelerating the recovery. So this can be a little bit of a mouthful, but I just want to briefly review all the things that were done in this systematic review because it is very heterogeneous. So in this, the interventions included techniques that were either manipulations or mobilizations applied to the thoracic spine or cervicothoracic junction. Studies were excluded if they used manual techniques applied to the shoulder girdle, which is what I mentioned before, without a control. And trials that used exercise in all treatment arms were included. Trials supplementing the thoracic manual group with exercise focused on restoring that motion were also included. The specific treatment techniques varied widely between studies, ranging from one high-velocity, low-amplitude thoracic manipulation to a series of 10 mobilizations and manipulations to the cervicothoracic junction and thoracic spine. All studies were only joint-based, no soft tissue techniques were included. 3 studies matched the treatment to the patient, while 4 used the protocol manipulations, and treatment varied from a single application to 6 sessions over 12 weeks, and then 5 of the 7 trials supplemented the thoracic manual techniques with exercise. So again, a lot of heterogeneity there. But they found that all 3 of the RCTs in it found statistical significance that accelerated the recovery and reduction of pain and disability from 12 to 52 weeks. So it's actually looking more long-term. And then 76 to 100% of the patients in 2 pre-post-test studies demonstrated immediate changes in pain scores beyond the MCID. I just want to briefly talk about some other studies here. But another study just looked at specifically patients who had shoulder pain presenting with what deemed as upper rib syndrome, which they define as patients demonstrating on the physical exam linking shoulder pain with dysfunction to the cervicothoracic spine and adjacent ribs. The issue with this study, it was very inclusive and very specific exclusion criteria, making it less generalizable, and only had 10 patients. Patients were treated for 2 sessions, the first one only being a rib manipulation, and the second visit only being a thoracic spine manipulation. The only advice I gave the patient was to maintain usual activity within the limits of their pain. The study found clinically meaningful reduction in shoulder pain and disability after 2 sessions that was retained at the 3-month follow-up. Another case study was about a patient with adhesive capsulitis. In the first 10 visits, they weren't really getting much progress at all. Then the physical therapist found some thoracic hypomobility deficits and range of motion deficits in the thoracic region, so she addressed those with different manual techniques. And after 4 visits of the thoracic manual techniques, the patient substantially improved their pain, range of motion, and function compared to the first 10 visits alone. All right. Now going to the lower quarter, so we have one study actually looked at neural tension. So it was a test-retest study, and the purpose was to investigate the effect of nonspecific spinal manipulations on lower limb neurodynamics. They used a straight leg raise test, and measurements were taken pre and post. It included 22 young healthy subjects with normal neurological status. And it found that after the thoracic manipulation, range of motions for the first onset of the neural stretch, the straight leg raise, and the maximal tolerable neural stretch of the straight leg raise were actually significantly raised compared to the pre-manipulation of the thoracic region. And we actually did this in residency a year ago, or yeah, I guess it's about a year ago, when they did it on me, and again, it actually does work. So again, if you have a patient with lower quadrineural tension, and you screen the the lumbar region, you cleared all that, you got it all better, and they still have some tightness and it's not going away, take a look at the thoracic region. All right, so just some things about autonomic system. So it was found that the neuroendocrine mechanisms play a crucial role in modulation of pain and inflammation. The study wanted to determine the short-term changes in the sympathetic activity in changing the cortisol and testosterone following a thoracic manipulation. The subjects were randomized to a sham intervention group and a thoracic manipulation group, and the study found statistical significance in changes in the salivary cortisol levels and testosterone cortisol ratio many hours following the intervention. Now, you're like, what does this have to do with anything? This will tie into a case study I'm talking about after this. But limitations of the study were actually only healthy males, no females, and no symptomatic individuals. However, effect sizes change noted in this study were considered medium, but that sympathetic response is known to actually be minimal in healthy individuals and has been shown to actually be amplified in painful populations. So the magnitude of the effect should theoretically be bigger in patients who are symptomatic if you do a thoracic manipulation affecting the autonomic response. Going back to that case study I mentioned, so this one was about a complex regional pain syndrome. Patient was a 38-year-old male. She had a traumatic injury to her left hand, had an ORIF, in and out of PT over 5 months. Then after 5 months, she decided to find another PT. The patient still had severe pain, immobility of the left upper extremity, dystrophic changes, and she had limitations with ADLs and was unable to work. So total with this new PT, the visits were 3 months, total of 36 visits. Early on in the treatment, the new physical therapist focused on cutaneous desensitization, edema management, and gentle therapeutic exercise. But she also found hypomobility and hypersensitivity of the thoracic region in T3 and T4. So after she found this, she addressed it immediately with thoracic manual techniques, and afterwards, the patient had significant increase in left hand skin temperature and decrease in hyperhidrosis and allodynia. The shoulder range of motion increased from 135 to 175 degrees, and the pain dropped by 3 points, which is an MCID, which is 2 in a pain scale. Because of this, it allowed for more earlier on functional rehab in the treatment plan. So again, why would this happen? Basically, how the sympathetic chain lies close to the thoracic region, and then thoracic dysfunction may compromise the chain ganglia and be linked to upper extremity symptoms in CRPS. And because of this manipulation, it may stimulate the sympathetic system and relieve mechanical pressure on the sympathetic system. All right, so some treatment options that I've done that we've learned about to address all these things. So manuals addressing the upper thoracic mobility deficits. These are usually more extension deficits, but you have the supine upper thoracic HVLA manipulation or pistol grip. You also have the seated up, and that's the picture on the left. And then you have the seated upper thoracic cervical CT junction manipulation, which is the one on the right. Now, manuals addressing mid to lower thoracic mobility deficits, ones that are more for the sagittal plane. Again, it can address all kinds of motion, but primarily sagittal since the thrust is posterior to anterior or anterior to posterior. So you have the seated middle thoracic spine manipulation. This is more commonly done for flexion, just how it's done. As you can see, that's the one on the right. This is also called seated J. People might know it as. You have the prone middle and lower thoracic manipulation, what we call prone screw home. And then you also have basically the pistol grip, but for the middle and lower thoracic region. And the one I like to use a lot in the clinic, which is more for rotational movements, it's a thoracic snag, and that's the one on the right. Basically, if a patient has it's more of like a mobilization with movement kind of thing, but you basically find the spot that hurts or the spot that doesn't hurt, and you just help the patient, assist them in the rotating into that painful range. And the goal is they should have less pain or no pain with this snag going on. And then just the one on the left is the prone screw home, and the one in the middle is the pistol grip. And then for other things, addressing the ribs. So you have the first rib inferior glide mobilization. You can do it in seated or supine. Supine, you can get a little more creative with it. You can actually hold it and have the patient exhale and inhale to kind of get a mobilization with movement. You can also hold it and have the patient lift their arm up supine until they feel like they can't go up any higher and go back down. Then you have basically the pistol grip manipulation, but on the ribs instead of the thoracic spine. And then you also, the one on the right, which is another one of my go-tos, is the first rib self-mobilization with movement. So basically you get a belt, a strap, you wrap around your upper neck here, and then you kind of, it's like a satchel, Hangover reference, the movie, but you put it right there and you basically apply pressure towards your opposite hip. So it goes from here to here, and as they hold that pressure, they're side bending. They can either side bend to the right for a couple seconds and then come back, or they can hold that pressure and lift their arm up in the air. So just like the mobilization, or the one that we do ourselves, but they hold it themselves and go up till they can't go anymore and then go back down. And typically when I've seen, it's a good supplement to our first rib mobilizations and actually get some really good carryover effect. And that is my presentation. Steve, now I click on the question thingy. Okay, and then that's that. So if anybody has any questions, both here and online, feel free to type. Do I unmute everybody, or is there just type it in? Okay. Okay, unmute yourselves, Steve said, and then I'll answer it, or if anybody here has any questions.
What questions do you guys have?
So from that study where they were testing the autonomic system, why do they think that thoracic manipulation is changing cortisol levels?
Because of how in close proximity it is to that sympathetic chain, they think that there could be a mobility deficit there that could actually be tightening it up and not having it be as efficient, the sympathetic chain or sympathetic nervous system not as efficient. So they think that kind of like the neurophysiological effects of manipulations, like we don't necessarily know exactly what manipulations do, but we know it can affect neurophysiologically, it can affect mechanically, kind of like that. This is more of a neurophysiological effect, and then they were just looking at that basically because of that anatomical relation to see if it can affect that.
What are the questions you guys have?
I don't know, with any of your research, is there anything about thoracic manipulations or even just mobilizations and like effects on headaches?
Yeah, I mean, yes. So it is shown to affect headaches. Basically, that's something I didn't include in here, but kind of like mechanical neck pain, how there can be a lot of stress on the upper thoracic spine, mainly because of that graph. It showed that percentage of the neck movement and how much the thoracic spine can affect it. But if that's tight, you're gonna have a lot more stress up here, and sometimes, especially even if it's upper cervical, patients can have headaches from upper trap referring to the head. So if the upper trap's overworked, it could be just because the cervical spine's overworked, and then if you address, and that could be overworked because the thoracic spine is tight. So just through that link. But yes, short answer, yes.
The study that they did on the neuroglides, the Pancreas improvements, what region of the thoracic spine specifically they were manipulating?
It was at a tension point, like the T6 region. Yeah.
Anything on that?
Nope.
All right.
Just the guesses.
Well, thank you very much. Again, make sure you sign out if you're New Jersey. Otherwise, you don't have to sign out. And then look for my email.